Good evening, everybody. Good evening from Jeddah, Saudi Arabia. It's good afternoon for some of our colleagues, and it's good morning somewhere in the US and Canada. It is it's a great pleasure to be here with you today to present this seminar with the distinguished speaker that we have. And the seminar is, the name of the webinar is Laboratory and Clinical Application of High Sensitive Cardiac Troponin Test. That is organized by Saudi Society for Clinical Chemistry. And our presentation today is High Troponin I, a paradigm shift from diagnosis to cardiac risk stratification in patients and healthy individuals. I know it's a long sentence. You're going to enjoy when we go into the presentation also. It's going to be presented by our distinguished speaker, Dr. Ajami Bashiri. I'm just going to tell you a little bit about Dr. Bashiri. He is a Senior Medical Director of Medical and Scientific Affairs for Abbott Diagnostics. Prior to his work at Abbott, Dr. Bashiri's medical background encompassed internal medicine, laboratory medicine. His clinical experience included the Brooke Army Medical Center in Texas, the 452nd Combat Support Hospital in Wisconsin, and Aurora Advocate Clinical Laboratory in Wisconsin and Illinois. Dr. Bashir completed his education and training at University of Wisconsin, Unified School of Medicine, and the Academy of Health Science, U.S. Army. Dr. Bashir is a member of several organizations, including American Medical Association, American Heart Association, the International Council of Standardization in Hematology, International Society of Laboratory, International Society of Laboratory Hematology, European Hematology Association, American Society of Hematology, and American Society of Clinical Oncology. He has also served on guideline subcommittees for Clinical and Laboratory Standards Institute, CLSI. In his current role, he developed and leads the medical research and medical education strategy for Abbott Diagnostics. He and his global team of physicians and scientists are dedicated to elevating the standard of healthcare through research and education. This includes supporting over 350 published studies in cardiology, oncology, infectious disease, and hematology. Most recently, his focus has been on the gender discrepancy in acute cardiac syndrome, myocardial infarction, diagnosis, management, and outcomes. I have met Dr. Bashiri actually on exactly 11 June 2015 when he walked into our lab. At that time, we were switching from the traditional troponin to high sensitive troponin after we did our validation. And we sent our memos to all our physicians, cardiologists. We also needed to have a physician education. And we talked to our partner, Abbott Diagnostics, and they arranged everything. And one day, on 11 June 2015, Dr. Bashiri just walked into our lab. And we walked together to the cardiology center, and he gave a very nice presentation about introducing the high-sensitive troponin to the cardiologists, the emergency physicians, and that presentation was beautiful. And today I'm looking forward to hear his presentation. With that, Dr. Bashiri, I will give you the mic and I'll mute mine. Thank you. Please go ahead.
Well, assalamu alaikum and good evening to everybody. I really appreciate the very nice introduction, and I'm humbled because it's probably a little bit overdone. And we're going to have to shorten it quite a bit. But Jazak for the effort, and I really appreciate the accolades. Most important to me is the response in 2015. Although we just together looked at my profile pic on this event, and it looks like even that is probably prior to 2015. I'm a lot grayer these days. But I appreciate hearing the feedback, and I also appreciate hearing that the implementation has taken place. There is quite a bit of challenge to implement something novel, to implement a paradigm shift. And today we're going to talk about another paradigm shift. So please make sure that in the end, any questions, comments, criticisms, you share with us, because I learn a lot from those, and hopefully maybe some of them I can give a good response to that will be effective and positive in your day-to-day practice. So as you all know, high-sense troponin has been around a long time for the acute setting. Troponin itself has been around even longer for the acute setting. And today it's a paradigm shift over to the non-acute setting. And we'll talk a little bit about that, but I know that the intro did include the fact that I am an Abbott employee, but we always put this in as a disclaimer just to make sure everyone knows. The issue at hand that we're trying to resolve with our novel and high sensitivity troponin I approach is really this. We have a pandemic in our hands today with COVID. However, that does not at all diminish what our global crisis really is, which is cardiovascular disease burden. This is a WHO slide. It comes directly from the WHO website. You can feel free to search it and find it on the WHO site, where the top line here is over the next 30 years or so. This was obviously set in 2008. You'll see this huge discrepancy, and maybe even a few orders of magnitude greater than these other disease states, possibly even combined, for cardiovascular disease mortality. And this is just continuing to rise. Today, the COVID pandemic is only adding to this, and it's not diminishing this by any means, because of the endothelial damage that occurs in COVID recovery and the sequela resulting in fibrosis of many organ tissues, but specifically in the cardiovascular space, where cardiac myocyte fibrosis may end up increasing the mortality rate here even further. So where we would like to do is have an impact on this global issue of cardiovascular by introducing a novel methodology, a novel variable that would help us make better decisions, optimize, or even titrate management of individuals and subjects that may be having cardiac injury. And we're really not looking at that at all. We're following our classical risk stratification factors, our classical signs of cardiovascular disease, historical family, and so on, and that has gotten us this far. So the current methods, as we mentioned, in some cases are quite general in correlation to the risk of heart disease. If we're talking about the most commonly used risk stratifier, it is actually cholesterol. Globally, that is probably the #1 implemented diagnostic cardiovascular risk marker to date. And of course, today we are much fancier, and we have guidelines and recommendations around the lipid profile, LDL and HDL and ratios and so on, and maybe even additional lipid fragments. Blood pressure, of course, is also utilized. However, these are not necessarily direct measurements of cardiac myocyte injury, cardiac myocyte death, or cardiovascular risk. They are correlates. And then, of course, we have even additional tools that we take these variables and combine them into calculators. One of the most famous ones that comes out of the Framingham cohort is called the Framingham risk calculator. And they're heavily dependent on how those cohorts were developed, how those cohorts were tested, and who was included in those cohorts. So there are limitations around how these tools operate and how these tools are actually going to give clinicians guidance on managing risk and preventing cardiovascular disease. So here's a comparison that was published on several tools to look at risk stratification. And as you can see, they all perform quite differently. I mean, here we can see that depending on the population, depending on even the geography, you may either overestimate or underestimate risk. And that's because they are not necessarily patient-centric and they're not applicable to everybody. And they may lack specificity to begin with. As we said, we're trying to take multiple variables, combine them, and attain specificity to cardiovascular risk. So that brings us to high sensitivity troponin and how we can utilize this and perhaps apply this to a space where it's never been applied, and leverage its analytical capabilities and its sensitivity, and utilize that variable in a slightly different way, in a different indication than what we have been typically used to in the acute setting for patients showing up suspected of heart attacks, and trying to diagnose them whether they are having a heart attack or not. So we know that high sensitivity troponins, especially high sensitivity troponin I, is very specific to cardiac myocyte injury. Remember, we've gone away from cardiac myocyte and necrosis and infarction since the third universal definition of MI, and of course now the fourth universal definition of MI. Troponins are really picking up and detecting and informing us of cardiac myocyte injury. Depending on how much injury there is, then we try to get into additional interpretation of that analyte and the concentrations over the period of time, usually within an hour, 2 hours, 3 hours of serial sampling. Then we say the dynamics, the delta, the concentrations. In addition to clinical factors, we will say that this is an infarct. Now, I know you may have seen some publications that talk about certain thresholds of troponin, talking about reversible injury versus irreversible injury. I'm still a little bit shy on that. High sensitivity troponins have shown correlation with imaging in this setting. As I said, their level of specificity and sensitivity may give us additional information that we couldn't capture on these subjects that we look to prevent cardiovascular disease. Why? Because these subjects are coming in asymptomatic. They may be coming in for a very normal health checkup at the age of 40 or 45 or 50, which I believe is by some of our guidelines in certain countries. So one of the studies that was done to show high sensitivity in this population for prevention was the association between HS troponin I and coronary artery calcification. And this was a Danish cohort that was studied quite a few years back, showing that if we were to look at high sensitivity troponin I and compare that to the coronary calcium score, we would see that high sensitivity troponin I may even have some additional capability than a coronary calcium score. And why is that? Well, a coronary calcium score is quite stagnant. It's quite stable. You're not looking for coronary calcium changes or deltas. And a high sensitivity troponin is not going to pick up only central lesions like we do in a coronary calcium score. We're looking at central lesions. High sensitivity troponin is going to pick up anything that is coming from the periphery and impacting the flow of oxygen to cardiac myocytes. So therefore, we tend to be a little bit better than the coronary calcium score itself. And this was in a population where high sensitivity troponin was compared to the coronary calcium score and the Agatston score And we detected in 29% of the lowest quartile high sensitivity troponin versus 55% in the highest quartile of high sensitivity troponin. And these are very low concentrations. We're talking about concentrations of 5 nanograms per liter or lower. And this correlation led us to another study, which is also an imaging study correlation. This was a population of 248 subjects. Yes, they are older subjects, 70 years old. And we looked at them with MRI at baseline, where they had no cardiovascular lesions. They had no occlusive disease at that time. And then did a follow-up at 5 years on those same subjects with MRI and compared it to the baseline high sensitivity troponin. And on a log scale, the higher the concentration of high sensitivity troponin, the more the likelihood of proportion of occlusive disease that existed measurable and visible in MRI. Therefore, this tied us very well to the capability of high sensitivity troponin to be able to detect and predict the increasing occlusive disease in the elderly. So we had a study against the coronary calcium score, and then another study here looking at a MRI in the elderly patients that had undetectable MIs. Again, these folks did not show up in the emergency department with symptoms. These were undetected MIs, and looking at a 5-year follow-up where the baseline troponin was very predictive. So where's the clinical evidence that this works? Sure, we made some correlation to other methods, and these methods are pretty hard diagnostic methods. They're imaging methods, meaning we probably don't get harder evidence than that in prevention or risk stratification of subjects. But the clinical evidence really comes from a lot of data. As you can imagine, when we're looking at the general population for cardiovascular disease prevention, we have to look at populations or cohorts that we can study with a lot of follow-up to determine if this sits true in that general population. Because remember, the coronary calcium score study of 1,000 plus and the MRI study in the elderly population of 248 or 250 or so subjects is really not the definitive answer that this is enough data to implement something like this or to recommend implementation. So then the investigators that had a lot of interest in this out of Hamburg at the Eppendorf Cardiac Center formed a collaborative called the Biomarkers Consortium, which they utilized 20 cohorts throughout Europe, multinational cohorts, looking at the general population that had no previous history of cardiovascular disease, and then had a 14-year follow-up so that we can determine if the baseline troponin was predictive and indicative of their outcomes at 10 years. As you know, for cardiovascular disease prediction, we're always looking at a 10-year span. That's what the Framingham score is, ESC score, and pretty much every other cardiovascular Q risk, if you use Q risk in Saudi or not. But here, this is a pretty large cohort. Combined, it was about 100,000 plus subjects. And after they did a data cleaning and looked at all the biobank samples that were available and they were able to do the study, they ended up with about just under 75,000 subjects, which is a mammoth of a study. And then, of course, the mean age baseline was at 52 years old. And that's clearly assuming that we had quite a few younger individuals in the study, but we also had some older individuals in the study. To me, I think part of the issue is in our cardiovascular disease burden today is we definitely risk stratify way too late in our lives. And recommendations, I think, are, again, based on those cohorts that were studied 30 years ago. They saw a risk, and then they made recommendations based on those. Yes, it's data, but a little bit too late. You can imagine that if we're going to see a 52-year-old with a high-risk cardiovascular disease and troponin levels that are high, blood pressure, lipid profile is unacceptable and is referring to a high-risk individual, we're going to start impacting them and try to improve their risk or decrease their risk from that point on. Their risk didn't start at 52. It probably started at 42. And some folks at birth, if it is a genetic predisposition, or maybe at 32 or 22. So we are looking at this quite late, and that's something to keep in mind as we go through the discussion today. And Biomarkers took this population, they broke it down into quintiles here, where they were looking at both the male and the female population. They were looking at cardiovascular mortality, cardiovascular disease, which is a softer outcome, and then, of course, total mortality. I'm not a big fan of the last category here, as all-cause mortality is something that I don't know how to intervene and I don't know how to fix. But cardiovascular mortality and cardiovascular disease, there's something that we know we can do something about. And we know that there are interventions that work, that improve outcomes, and that decrease risk. And hopefully we also get to have additional interventions out there. But just simply a lifestyle change alone is positively impactful, let alone starting to impact some of these underlying causes of this cardiovascular disease or the cardiovascular mortality. But as you can see, I mean, the highest risk population, it really starts above these levels of 5 to 9, and I believe 12 is where we picked up that high level risk in males from this Biomarkers study. And these are not 99th percentiles. You know, these numbers, these concentrations are not what you use today for evaluating suspected AMI patients in the emergency department. These concentrations are much lower than that. And the Heisens troponin assay was also used with CRP because, as you know, CRP is in guidelines. CRP has been studied quite intensively alongside anti-lipid treatments. We know that there's an inflammatory response that ensues in cardiovascular disease, and the higher the inflammatory response, the higher the risk of cardiovascular disease and poor cardiovascular outcomes. We know this. However, CRP is not produced by cardiomyocytes. So therefore, again, it's a nice correlate. It's a good assay to have in conjunction, but not necessarily a specific or sensitive assay for cardiovascular disease itself. In combination as one of the variables in a multivariate approach, CRP is still there, of course, and that's why it remains in guidelines. So we wanted to take a look at Heisens troponin and CRP in the same cohort, and this is the Hunt cohort coming from Professor Olmland and colleagues out of Norway. As you can see, it's a pretty decent sized cohort. You had over 9,000 subjects included with no known cardiovascular disease. And then 733 actually reached a composite endpoint of having hospitalization for acute myocardial infarction, heart failure, or cardiovascular death in that 13 or almost just under 14-year follow-up. And this is where, Heisens troponin greater than 10 nanograms for women and 12 nanograms per liter for men was considered part of the composite endpoint for hazard ratios of 3.6 and 3.61 versus HSCRP greater than 3, which is considered to be high risk, of a hazard ratio of only 1.7. So if somebody on the call here listening likes hazard ratios, you know that that's a drastic difference. And there's reasons why, and we'll get into the data in a little bit. So we did look at models of net reclassification index. Of course, we don't want to alarm anybody that Heisens troponin is going to reclassify everybody in such a way that you have to reevaluate everybody. That's very important to note. And then the capability that a Heisens troponin can provide additional information and be superior to that of HSCRP in this setting. So the first thing I would point at, which is most important when we compare Heisens troponin and HSCRP, is the way that they stratify that population. And the level of stratification is extremely important, because if we look at the data and analyze it statistically, look at 95% confidence intervals around that data, if the populations don't have enough spread of stratification between themselves, there's going to be a lot of overlap. And this is what HSCRP does. So HSCRP less than 1 is considered to be low risk, 1 to 3 is considered to be moderate risk, and greater than 3 is considered to be high risk. So as you can see, there's very few people in the low risk category, and the moderate and high risk make up the larger bulk of the population. And what we're saying with Heisens troponin is specifically for cardiac injury, these subjects are expressing cardiac injury that is low risk in nature, or they're expressing cardiac injury that is moderate or high risk in nature for cardiovascular disease to happen, or hard cardiovascular outcomes to occur like AMI, heart failure, ischemic stroke, and so on, and cardiovascular death. So if we look at the low risk population, that is the largest population in this cohort, while the high risk is a very small proportion. So Heisens troponin is not an alarmist response. It is not going to cause an increase in evaluations to the degree that, there may not be much value in that assay. What I mean by that is if I take HSCRP above 1, I have to evaluate everybody. And then, maybe HSCRP is not a very good indicator on who I focus on, because it's asking me to focus on 80% of the population. But if I take Heisens troponin as the added variable in my assessment of cardiovascular disease risk in a normal individual or in a health check, then I can say, well, now I know who to focus on. Who is expressing the most troponin release? That person is expressing the most cardiac myocyte injury. And we have to figure out how we decrease that cardiac myocyte injury, because we know that correlates very well with poor outcomes in the next 10 years. So one of the approaches that we looked at is, how do we actually do that? How do we decrease that cardiac injury? Because we already have therapeutics and interventions. We have lifestyle change, we have antilipids, we have aspirin, we have additional anticoagulants that we could possibly use if needed, if it's at that severity. But we have antihypertensives, which is, I think, one of the major cases that we don't control as well. The SPRINT study showed that, we could lower it from a control point of 140 to 120 milligrams of mercury for a systolic blood pressure, and the outcomes improved quite drastically. But we looked at the antilipids to begin with, and this was a study coming out of Scotland by Dr. Omland and colleagues, where they looked at the WASCOPS cohort. The WASCOPS cohorts was in over 3,000 men with a 5 and a 15-year follow-up, meaning that they did have serial sampling, the baseline and another serial sample for follow-up, and the age was between 45 and 64. So it wasn't a very elderly group, obviously. This is the group that we're extremely interested in decreasing risk over the lifetime of the population. So the WASCOP study is looking at pravastatin in this population where a raised cholesterol existed. So we had one classical risk factor there, but we wanted to see how troponin reacted in this population. We already know that the pravastatin trial was positive, right? So when we looked at baseline troponins and we compared that to the troponin at the serial sample at the follow-up, what we noticed that is if the troponin didn't change, the risk also didn't change. And if we notice that the troponin increased, that was more likely to show additional poor outcomes. If the troponin decreased, right, and if the troponin decreased by a certain percentage, and this was statistically significant, then we also saw a decrease in poor outcomes, or an improvement in outcomes, if I was to say it another way. And this is where we can say now, with high sensitivity troponin, not only are we able to risk stratify, but when it comes to the intervention, post using it for screening and risk stratifying, we can actually now use it as a trigger above and beyond the lipid profile and look at the folks that are actually benefiting from this treatment, either titrate, change their therapy, or if they're not benefiting from the treatment, then perhaps they don't necessarily need lipids, antilipids. Although the UK and NICE have looked at quality life years in HEOR models post antilipid treatment, and they like to put it in the water. I'm not a big fan of putting anything in the water other than water. So perhaps we utilize better variables, better diagnostics to make even better and optimize our decisions, even in the setting where we've been practicing with antilipids for many years now. So it does give us evidence that troponin is modified when the risk is decreased, and it's with current standard of practice interventions. And if you're not a fan of pravastatin, you like rosuvastatin, or you like another statin, then that's great. So when we look at the application of high sensitivity troponin, we can look at a study that was done by Dr. Morrow and colleagues, and this is coming out of Brigham and Women's in the US, the Pegasus trial that was done a couple of years ago and also published, which was a pretty large trial. We had over 8,000 participants enrolled in this trial, and it was really about the prevention of cardiovascular events in patients that had a prior event using ticagrelor compared to placebo. This is not necessarily primary prevention. This is really looking at secondary prevention, if I may say. And high-sense troponin works in secondary prevention as well. And if you can imagine that if a diagnostic marker is sensitive and specific enough to pick up cardiac myocyte injury in the acute setting, where we want to diagnose suspected MI patients, in the non-acute setting, where we want to risk stratify asymptomatic individuals and determine their risk overall and intervene for primary prevention, cardiac myocyte injury is the same in all the settings. How much injury? That's a difference, of course. How quick the injury happens, the dynamics of that injury, of course, is a difference. It depends on the etiology and the insult that is taking place on those cardiac myocytes. But once injury takes place, injury is injury. It is no different in any setting. So if that cardiac biomarker is sensitive and specific enough in the acute setting, it's going to be sensitive and specific enough in the non-acute setting for primary prevention as well as secondary prevention. Of course, the cutoffs and the thresholds and the utility is different. So in primary prevention, we're looking to risk stratify, first of all, to categorize them appropriately and perhaps initiate some kind of therapy. In secondary prevention, we're looking to monitor and determine if the current therapy is doing its job or not. So the utility, of course, changes, and we may be looking at thresholds differently. And that's exactly what they did, is they looked at it in two categories here, in the low risk and the very high risk for ACVD with high sensitivity troponin. And so they looked at something that was below the limit of detection, which for our assay is 2 nanograms, and something that was above the 6 nanogram per liter threshold, which they called a high-risk population. And obviously, we can see that the folks that were in the very high-risk population with a low-risk high-sense troponin, but they were considered to be high-risk, they did not benefit as much from the therapeutic. And the ones that had a high risk with high-sensitivity troponin, but could have been either low risk or high risk by the classical assumptions, those folks benefited the most from being categorized with high-sensitivity troponin above 6 in the high-risk category. Again, even in a secondary population, the data shows us that we have a utility where high-sensitivity troponin stratifies the groups very well and actually gives us a very good description, or I should say, delineator between the folks that would benefit and the folks that would not benefit from a certain therapy or not. Does this trial tell us that, we may also have a trigger here, like I would say in the antilipids? Perhaps, perhaps not. But I would also say that we probably need a little bit more research in the secondary prevention with specific drugs like ticagrelor. In the antilipid space, that one is so well researched in the past, and the side effects are, of course, not at the level of ticagrelor. And therefore, I think the data in the antilipid space, including the Jupiter study, which I did not present, is warrant enough to be able to utilize that data in implementation. Here, this is a good sign that it can be applied even in spaces where these drugs that are of a bit more importance in criticality and need to be monitored a bit more, it works as well. Now, the last piece I'd like to talk to, and this is really to gain some interest from the group here listening today, is, we could have the best diagnostic tool since sliced bread. And if we do not generate data moving forward in implementation to show how it was implemented and to show the value of it, that will go lost in the archives of history of medicine, even though it may not be in the canon of medicine of Ibn Sina, but it'll go in the archives of the history of medicine, and it will be forgotten. So the way to do this most effectively is to monitor, capture, and report on data that is generated post-implementation. And this is what we call a registry approach, and it's specifically around cardiovascular risk, where we're doing continuous monitoring of those institutions that have implemented high-sensitivity troponin for this purpose. We look at the data almost live, as you can see in this snapshot of the dashboard of our cardiac registry in India, for those of you that looked at the geography here in the map. And it's at 6 sites of this institution across India. They are using it in their health check program. They have added high sensitivity troponin to their health check program as one of the test menu items. And automatically, we can see and report back to them and their clinicians not only the categorization of what's high risk, moderate, and low risk, but we can actually click on individual geographic locations to determine where the data is coming from, where the subjects are coming from, and look for trends. As an example, we also look at a risk trajectory analysis, and we can look at it by physician, by lab, by institution, by clinic, and say, well, at this institution, individuals went from high risk to low risk, and that's this dark blue here. Well, why don't we find out what they did well and maybe have them educate the rest of the clinicians where folks went from low risk to moderate risk or low risk to high risk? Because perhaps in your own institutions, in your own experience, you may have an approach that makes sense and is translatable to your colleagues across your geography, country, or even within institution. So this is a full feedback loop registry that is not just about research and publication, it is also utilized to improve care. Maybe I can say improve care on the fly if that translates well with the colleagues listening. So I'm hoping this will generate some interest. I would love to see a registry in Saudi, as we have already implemented in some other countries. And we will be looking at these registry data sets in silos individually for those countries, but also we will combine them into a universal report as well to look at a global cardiac registry data set. So in conclusion, guys, I mean, this is basically the highlight of all those slides, and I tried to keep it short and kept it within hopefully an acceptable time frame. But we do know that high sensitivity troponin correlates very well with imaging, can predict future cardiovascular events. It is actually responsive to interventions. I would love to show some lifestyle change interventions only, where we see cardiac injury actually decreasing with the measures of high sense troponin. So if you have any trials with lifestyle intervention only, this would be very useful to objectively measure whether cardiac injury is decreasing or not. And then, of course, it does change in parallel to risk modifications, and I believe is very well correlated to concentration versus when the event occurs. The higher the concentration when you're measuring risk and trying to determine their risk profile, the higher the probability that that event will occur earlier in that lifespan of the individual. And that's also very important, because today's measures of cardiovascular risk don't really correlate that piece at all. They're saying you're at risk, so your 10-year profile is no good, but that's about all that our correlates to risk tell us today. So I believe we have an excellent tool that can be added to risk stratification today. And I will stop there. I will open it up for questions and let our honorable moderator guide us from here. I hope this was informative and entertaining.
Thank you very much, Dr. Bashiri. I think I speak for all attendees if I say thank you very much. And that was an interesting presentation. A lot of information, new information to most of us. And at the beginning, you also took us from the history from the beginning of the traditional troponin, and we took a paradigm shift to a high sensitive troponin. And when you look back now with the COVID-19 pandemic, it's even more crucial than any other time to have such a tool like high sensitive troponin, let's say perhaps an ER setup, where you have a better patient flow, that you're not keeping patient for very long, using the algorithm with the high sensitive troponin, and how you can immediately measure within an hour or the 3 hours gap, and make people go to decide whether to admit or not. So that was an extra plus to the high sensitive troponin. But today you also took it for another paradigm shift, where you're looking for a risk stratification. So I think this is a beautiful topic. A lot of people benefit from this one. And everybody agree that we want to see this in the future. It's a better thing to know what, when you predict something and you stop it, like you said, you start treating now instead of waiting at the last minute. And I don't see any questions for now. It looks like on the chat, I don't see, maybe the technical people can help us with that one. But I have a question of my own. After hearing all this now, what do we do with the result? What are the physicians supposed to do with the result? What is the lab telling them? Let's see, we say, okay, this is the result. This is what's happening. Now, just put us to the scenario where now let's go to the real world where, okay, we did this test, we sent it, we gave them the risk range up to 10 and the 12 for males. And what is it now? What's happening? So can you just please elaborate on that one?
Well, yeah, and that's an excellent question. I think this is where we really need to focus on in implementation and educating before we get to implementation. So what does it mean? What do we do different? So we've got low risk. Those folks are usually okay until their next checkup, whenever that may be. guidelines are quite loose on when we request folks of low risk to come back for an additional checkup. But what do we do with an individual in the moderate risk category with Heisens troponin? And what do we do with an individual in a high risk category of troponin? First, where that level of risk is aligned with your current risk calculator or your current risk tools. Let's say you're only using Framingham, and Framingham says this is moderate risk. Heisens troponin says this is moderate risk. While we don't recommend any changes there, we recommend that you follow your standard of practice and monitor to see if Heisens troponin gets modified and decreases. Because remember, if you're going to use coronary calcium score or even some of the other scores, or even a lipid profile, a decrease of a lipid profile is only loosely associated with improvement in outcomes. If we see Heisens troponin also decrease, so let's say in the moderate risk for a female, we're looking at a troponin of 8 nanograms per liter. And they are moderate risk by Framingham or Q risk score or any other score that you may use. And you have to initiate therapy because everybody gets a lifestyle change consultation. That's guaranteed. Everyone should get one. If they don't, I hope they're getting it. But from a intervention, if the lipid profile is what we're intervening on to decrease the lipid profile with antilipids, and we may be decreasing the lipid profile, they come for their next follow-up at 6 months or a year because we do LFTs and so on, and we see that the lipid profile is improving, but Heisens troponin is not improving and may be increasing, then we need to look at other risk factors we may have missed, or we need to look at changing their antilipid therapy because your cardiovascular injury has not improved. And that's what it means in implementation. And the same is applied in the high-risk setting where you may agree with Framingham. And those, I think, are very intuitive. I mean, that follows logic. Where the challenge really comes into play is I get asked again, well, what about when we disagree with the current standard of practice calculator, right? When that disagreement is there, let's say we're saying it's low risk with Framingham, but Heisens troponin gives us a 12 or a 20 or a 15 in an individual, and it could be a very young individual. I'm going to give you an example here, and I'm not going to put up a slide because these are going to be in publication soon. But at one of our risk registries, a 54-year-old man walks in and has a troponin result, absolutely normal, absolutely healthy. His company is paying for his wellness check every year, walks in and has a high sensitivity troponin I result of 248. This is a happy-go-lucky guy. His ECG is absolutely beautiful. No diabetes, no hypertension, and ends up going to the ED for a workup as a suspected MI patient. And of course, has an LAD, has an emergency stent done. And what do we call an LAD? We call an LAD a widowmaker. And that's why, because they can be silent up until the point that there is rupture and a thrombus, and it turns it into a type 1 MI. Well, you know, once it's a type 1 MI and we can pick up a STEMI, that's not prevention anymore. You know, that's the acute setting. So that's a very small example of where we pick up these silent cases that exist in the population. And the only way we pick them up today is we pick them up as, cardiac arrest. Oh, yeah, I had a massive infarct, cardiac arrest. It happened all of a sudden. No, it started 40 years ago or 20 years ago, and we never looked at it. And this is where high sensitivity troponin, I think, is going to have a major play. The other piece is if we're disagreeing with Framingham calculators and other calculators, and we're saying high risk, and the individual is moderately above those levels where we don't think it's an acute issue, but we know that cardiac injury is happening, then again, we can titrate therapy, and we can initiate therapy if we didn't initiate therapy. Guys, we've everyone listening on the call here, we know that antilipids have additional value that we have not done very good research on. We know that they sheathe plaques that are unstable. We know that they have additional anti-inflammatory value that decreases cardiovascular risk. It is not just about antilipids and bringing your lipid profile to normalization. They have additional values, and there are recommendations that say you should think about antilipids even when antilipids are not triggered. So maybe perhaps after the WASCOPS trial and the Jupiter trial and rosuvastatin and pravastatin, we see this, we may actually have another trigger for antilipids that makes sense. And if they are low risk and we think they're moderate, high risk with high sense, perhaps this is a good wake-up call for that lifestyle change consultation to actually make sense to the patient and say, you know what, I know you don't want to improve your lifestyle or change your lifestyle because I can't find anything wrong with you with lipid profile and with anything else, but your high-sense troponin is giving me a 9, and you're way too young to be running around with a 9 or a 10 high-sense troponin. You really need to think about a lifestyle change.
Great. Thank you. That was a beautiful answer. You just put everything that most people, all of us say, well, Mr. So-and-so, he was very healthy, and all of a sudden he died of heart attack. You just explained it that he didn't just die of heart attack. He's been having all these things before. If he had gone for, if we had a test like this, he would have been caught. I see one question here from someone here, but before I go to that one, just for your one of your slides talking about the cardiac registry, I am not sure who we have in our audience, but I make sure we pass that to the Saudi Society for Clinical Chemistry, and through them we can look into it, because that has to be done through the hospitals, through the registry bodies, and inshallah, we promise you we will pass it to them, and they will. We will have a good work between, like you said, that Saudi has a bigger population in this area and there is the registry, so why not check with you? So inshallah, we will do that.
Inshallah.
Inshallah. One of the question I see here, any exclusion criteria to be used when considering high sensitive troponin as a risk prediction?
Well, I mean, one of the exclusion criteria you have to keep in mind, and I didn't show the exercise studies. Remember, there is injury that is reversible. There is injury that we put our cardiac myocytes through on a day-to-day basis. If you ran a marathon, or if you did some rigorous exercise, or you do endurance exercise for a profession, I mean, that's your profession, is your endurance athlete. You have to notify your clinician before that test so that you have enough time between your last endurance exercise event for your cardiac myocytes to stabilize, and then we can look at the troponin in concentration. There is a study outside of out of Norway again, and this was on amateur cyclists, and I'd be happy to provide the reference to the folks interested. But the amateur cyclists obviously prepared for a 150-kilometer race. They had done many races in the past. And we did baseline troponins. They did baseline ECGs. And then we did a troponin right after the 150-kilometer cycle race. We did a high-sense troponin at 3 hours, 12 hours, and 24 hours afterwards as well. So we looked at the kinetics of troponin in circulation post this endurance athlete event. And what we saw is that at baseline, everyone was phenomenal. These guys were great, okay? And everyone was not only below the 99th percentile, but everyone was below the moderate risk category. And right after the endurance race of 150 kilometers, everyone was elevated. Everyone was elevated above the 99th percentile. They weren't having a myocardial infarction. They weren't complaining of chest pain and left arm pain and neck pain and so on, but everyone had troponin results well above the 99th percentile. At 3 hours, you start seeing the kinetics and the curve on a downfall because it was reversible injury, right? And then at 24 hours, everyone went below the 99th percentile as well as below the moderate risk category, except for 3 individuals. These 3 individuals remained above the risk categories and one of them above the 99th percentile. And we ended up with 2 emergency stents and 1 elective. So what that means is you have to be cognizant of the exercise that you do. Tell your clinician before you get risk stratified with high-sense troponin so we don't alarm them with elevations that are expected. This is only normal. in cardiac myocyte injury when you're having endurance exercise, but it's reversible injury. And then what it also means is when we're stressing, remember the exercise stress or the drug-induced stress tests for endurance athletes, those things probably don't mean much. You won't be able to stress them at all because these folks were cycling 150 kilometers to determine that. They all had beautiful ECGs at the beginning as sports athletes. So keep that in mind, that this will also be a tool that we will utilize in stress testing, and you'll see that publication coming out soon as well.
Great, thank you. I still don't see any questions in here. There's a lot of questions related to CME hours, and that will be answered by our technical people. The question we were getting also when we first switched into our high troponin, and a lot of people asking to know why the low values, why all of a sudden this very low values is interesting. Anything around that?
Yeah, no, that's an excellent question. I mean, this really ties back historically to the contemporary assay and how we used to use troponin and the definition of MI. I mean, we used to use these very high cutoffs, not sensitive, but they were specific. And you know, me being a clinician as well as other folks in the clinical setting and in the ED setting, like that, because if it was you know, an MI, troponin was above that cutoff. They were specific. But what I'd like to remind ourselves is that they were not sensitive enough. So when high sensitivity troponins came up, we were testing a lot of normal populations to come up with 99th percentiles as the guidelines recommend. And when we were testing normal populations that had no history of heart disease, that met the criteria for normal, and we also benchmarked against cardiac biomarkers like BNP and so on to determine that they're normal, we saw troponin values that were measurable, were above the limit of detection, were above the limit of quantitation, that, you know, had excellent precision, less than 10% imprecision. So they were clinically relevant now. Before, the precision was not there, too much noise, too much variability, and it rendered the analyte quite useless at these low cutoffs, at these low concentrations. Now the analyte became clinically useful. So how do we leverage that clinical utility? So then we ended up running trials like Biomarkers and the Hunt and the Peace trial and so on, where those low concentrations did have a clinical utility. They were directly correlating to a cardiovascular outcome. So this is why today these low concentrations are important. And this is why today there are additional indications where high sensitivity troponin needs to be looked at seriously. And for the indications that we have CE marked and regulatory approved, like for risk stratification, need to be looked at for implementation.
Perfect. Thank you. Thank you very much. Let's say one final question I have. I don't see the questions here. I got all my questions here. Let's say people are interested. They hear you today, hospitals, cardiologists, or family physicians, and they want to implement this. They say, "Oh, you know what? I want to introduce this." What is the best way to do? Like, is it like physician education, and then you can just add the range into the laboratory's normal range? Let's say the normal range for a male and a female is this, and you want to add that risk stratification, say 3 to 10, and then as I think at 4 to 12, and just have them order it whenever they want, and the result and the range is there, and leave it up to the physicians, or how do we do about it? I think Dr. Ajim is having a little bit of technical problems. I see some other slides, it's frozen, but we will give him a few minutes. He's almost done, unless he has some technical issue. But in any case, we would like to thank him. It was a beautiful presentation. We would like to thank Dr. Ajim on behalf of Saudi Society for Clinical Chemistry. As I understand, he had a very busy schedule and he was able to make this presentation. He made some time for us. We spoke to him yesterday. He said he couldn't say no to give a presentation in Saudi. He was very interested and he's looking forward to visiting and doing more work like this with the Saudi here with the Saudi Society for Clinical Chemistry. And he was just telling me he's looking forward into even visiting and taking this to a next step. With that, on behalf of everybody, if Dr. Ajim is not able to come back, I would like to thank him on behalf of everybody. So just for 1 more minute, I think it's 8 o'clock now. We had up to 8:15. We're going to see if Dr. Ajimi can solve his technical problem and join us back. If not, I think we've asked him all our questions, and I think it was a very interesting presentation. I'll just give him one more minute. I don't see any message from the technical people also, so maybe it's only Dr. Ajim was having a problem. We still have the audience. I think maybe it's because of the time. I don't think Dr. Bashir is able to come back. I don't see anything on the chat. So I think we will just wrap up this session, and thank you for everybody who joined us. I hope this was informative for you as it was for us all. And we look, join the room, mashallah, Dr. Ajim is back. Yeah, he was having tips. So we'll give him a few minutes. I think it's flashing a little bit. He's coming back. He's trying.
Welcome so sorry about that.
Okay,
my network here decided to go off on us, but that's great.
Yes, I saw they went out, so I knew you were having a technical problem, but we're just telling everybody. I don't know if you heard my question. I think we're almost up for time, but I was asking you. I was telling them that we were thanking you just in case you couldn't get, you were not able to come back, but alhamdulillah, we are lucky you came back.
Alhamdulillah.
My question was, let's say if people are interested now, they see your presentation, they like it, either hospital or something, they want to implement it. So I know now, let's say in our situation where you have a high sensitive troponin, we have our range. What is supposed to do? The lab would add into their normal range that the risk stratification range, normal range for male and female, and leave it up to, and do a little bit of physician education, leave it up to the family physicians to just order it and keep the labs busy and have troponin ordered more than glucose. And what is this? What's the best way of implementing it without overutilizing and just to get the best out of this? I mean, this looks very promising in the future, but how can we do it now?
Yeah, so I think it comes down to really the point that we made earlier is we don't want to overburden and we don't want to overutilize and we don't want to cause clinicians additional evaluation that is unnecessary. And that's why I tend to show our registry model here that, you did a baseline on these folks. It wasn't a health check menu. Everybody's getting it. But after the baseline, as you can see, we're well nearly 60,000. I think today we're well over 60,000 participants. These folks are not going to get another troponin. They're not going to get followed up as a high risk or moderate risk individual. They may still be treated according to their plan or lifestyle change consultation because they may have classical risk factors or family history and so on, but they are not expressing cardiac injury that is of concern right now. So the folks that you would be following up on, and that is, again, according to your standard of practice, when you intervene on somebody that is of moderate risk, you have a follow-up strategy. We are not changing that. You would utilize your current follow-up strategy, but it is a moderate risk from high-sense troponin because there is cardiac injury that is being expressed. And therefore, to me, that makes a lot of sense because we're looking at a small proportion in your overall population. And then for the really high risk, which is an even smaller proportion, those are the folks that you probably bring in every 3 months anyway to do LFTs on because they're most definitely intervened upon. But the ones we benefit for the most from there is the ones that are the silent MIs that we capture and also the reclassification ones, meaning we've reclassified them because of high-sense troponin, and they end up coming to a high-risk category, and we're able to decrease their risk and manage that patient a lot better. The only way to get there and be able to do this is you have to implement it in your current risk or primary prevention pathway where it is part of that menu, because otherwise you won't be able to look at the whole population appropriately. Once you're done risking them at baseline, then you're only going to focus on that very small population. So we don't recommend overutilization. We don't recommend you repeating it on everybody and running it on everybody, but we do recommend you being able to capture at least at baseline the whole population so you can pick up the silent MIs, right? Because if I told you that 54-year-old required high-sense troponin, I'd be lying. There was no trigger to tell you why they needed a high-sense troponin or not. There was no symptoms, no family history, nothing there to tell us, hey, this gentleman is having some cardiac injury and it is of an acute nature, but is not expressing it. The same thing goes with the cyclists. They were all healthy. They're athletes. I mean, these guys are healthy. That's why they're getting on a 150-mile bike race, because they can handle it and they've practiced it and they've prepared for it. Nothing I can tell you that says, hey, you must look at high-sense troponin in these folks. So as part of your primary prevention program, baseline everybody with a high-sense troponin. That may mean that if you order, a lipid profile, hemoglobin A1C, glucose, and an ECG for a cardiovascular evaluation, or in a general health check, you're doing your chem panel, CBC, CRP, and so on, add a high-sense troponin. In your subsequent testing and follow-ups for the, I don't know what percentage this is. My math is terrible, by the way, guys. But and most of your population, you will not need to redo that. And in the follow-ups, you will be using it as a monitor to determine if you're decreasing cardiac injury, and therefore your intervention is effective. But
perfect.
Another thing I'd like to add here is please don't feel like you're alone going at this alone. This is what we did with high-sense troponin when it first launched. It is a paradigm. We realize that. But in order for us to have that maximum impact to that cardiovascular disease burden globally, to start seeing that curve come down, we're going to be right there and educate along the way. We've got cardiologists on the team. We have scientists on the team. And we've got an excellent Abbott global team as well as local Saudi team that can be of help. So we're right there with you to educate and provide the information, the resources needed for this to be a successful implementation. I don't assume that, people should take it and copy and paste it and run with it. I assume that it is even more work for us, and we are happy to do that work.
Perfect. Great. Thank you. I think it's hard to believe we're coming to the end of this presentation. At least I'm enjoying it. Someone has just put 2 questions. I'll give you one of them. Looks like when you're using high sensitive troponin for on the ER when people come in about the algorithm, and the other one is different. So let me read the 2 of them for you. So depending, you can answer. Mm-hmm. One of them says, regarding high sensitive troponin implementation, any 1-hour algorithms to rule in or rule out that is validated by Abbott. The other one is, how much total allowable error is used for high sensitive troponin? Is the method harmonized? So I think you can start I can repeat any one if you want me.
Yeah, well, let me start in reverse then. Let's get the total error out of the way. So you know that troponins have a pretty wide total allowable error. They have, and that's due to biological variation of troponins. If you look at troponin I and T, troponin T does also have a diurnal impact to its biological variation, where troponin I's do not. As far as biological variation driving the impact of a total allowable error in developing of the assay, that is a huge factor. Are they harmonized? Absolutely not. I wish they were harmonized. There are claims that, some manufacturers are harmonizing between their point of care and their core lab, or we could say that and say, hey, we have a troponin I in point of care, we have a troponin I in core lab. Overall, that is not the issue. The issue is, are they harmonized across methodologies, which they are not. Unfortunately, all of us are measuring troponin, but we're measuring a slightly different method, a slightly different portion of the molecule if it's troponin I, and of course T is a completely different molecule that is being measured with different kinetics, different rates of drop into circulation after cardiac myocyte injury, and different rates of being cleared by the kidneys. So metabolization in circulation is different for the two troponins. Keeping that in mind, however, the studies that we have done, which are so extensive, you're talking about hundreds of thousands of subjects, both in the primary prevention setting, meaning general population, and in the secondary prevention setting. And then I should probably say somewhere a couple of hundred articles that have been published in the acute setting with high sensitivity troponin. That biological error does not seem to impact our value and capability to either diagnose or risk stratify and prevent. So let's make sure we keep that in mind, is where's the clinical value? Because I can give you other assays with large biological variation, but clinically, when you put it into perspective and used in the right context, they have a lot of value. And in this case, we're not using troponin alone. We're adding troponin to the current standard of practice of multiple variables, not only diagnostic variables, but also clinical variables and genetic variables. That is very important. We're not saying throw those away, guys, but please don't misunderstand me. That is very important to maintain. The art of medicine cannot be thrown away with one assay, and it will never be thrown away. So the art of medicine needs to continue, but we want to add more tools, more precision tools, more patient-centric tools that will help us make better decisions. I hope that answers the questions to the two listeners.
Perfect. Okay, that was the first one, yeah. Okay, the other one was about the algorithm. Thank you.
The algorithm. So
you want me to read it?
No, I remember the algorithm. Has Abbott validated a 1 hour algorithm?
Wow.
So Abbott has looked and validated these algorithms, all of the algorithms, and they are done by investigator-initiated trials. They are in publications. So when we do a study or collaborate on a study, or an investigator uses our product to do a study and publish that science, those findings, to me, that is the most valuable validation. Validating internally, to me, capturing samples from a site and doing an Abbott validation, to me, that's a regulatory validation. So if you want data on 1 hour algorithms, 0 and 1 hour, which is the latest ESC, and I know what they're referring to, I'd be happy to provide the publications that show the capability of our assay compared to the other assays at 0 and 1 hour. However, that was not the topic of this discussion, as we're talking about the non-acute setting here, but I would be happy to have another discussion and go through all that data, as well as provide the data, because I know it's very important information to have when you're implementing this in the acute setting. I would like to say, though, I am leaning towards the future. If you look at the latest ESC guideline and the 4th universal definition of MI, I am looking towards the future and thinking beyond the 0 and 1 hour. You will soon see a publication talking about 0 and 30 minutes. But I'm even thinking beyond that, and Abbott is thinking, we are thinking beyond that 0 and 30 minutes. We're thinking at patient-centric approaches with machine learning. And if you haven't seen that publication, that's where we need to be. Remember, we have to be as precise and patient-centric as possible. And the improvements that exist in the acute setting would only come by a multivariate machine learning or advanced data analytics and AI capability that we have today with our computational capability. So the fourth universal definition of MI says the next best thing is going to be something that takes into account age, gender, the dynamics of troponin, right? The dynamics of troponin, and EGFR, which I'm not a big fan of, but we should also consider EGFR in that scenario.
Perfect. Thank you very much. Machine learning and AI is the future. I know you have the data. You might as well use them. That's computer right. Analyze for you and assist you with what you're trying to decide. That's beautiful thing. And I think with a lot of things in the lab and healthcare and medicine, that is the future. Looks like. And it's also great to know that you say this, we are not alone in this. Abbott is there to help and stand behind all these studies and all this product that is producing, and we really thank you for that. I don't see any other questions now. I think we've answered most of the question, and we're almost 1 hour above the time that we were allowed. On behalf of everybody and on behalf of the Saudi Society for Clinical Chemistry, I'd like to say thank you for this beautiful, interesting, and informative presentation. Questions were a lot. I think at the beginning we didn't have, but a lot of interesting questions came up. We really enjoyed that. We look, as you said yesterday when we were talking, we look forward to have a lot of these discussions with you. We would also like to welcome you here, inshallah, in a better healthcare situation. Inshallah. And I would like to thank you very much. And the mic is yours if you have anything to say before we finish.
Well, all I'd like to say is thank you for having me. It's very humbling, and I am humbled to be a presenter. But inshallah, I agree with you that we can be a visitor in person. I really like the online interaction, but it never replaces the face-to-face interaction. I may look scary at times, but I grow up people, so the face-to-face interaction is irreplaceable, and inshallah we'll get to it soon.
Inshallah. With that, we'd like to thank you very much, and I think we will end the session here. And thank you, everybody. Thank you for attending, and thank you. And as far as I see, a lot of questions were about the CME hours. I think the technical staff they will send you the emails with that after the presentation. There will be a survey that you fill up, and then from that one you can get your Saudi Council 2 hours of credit. Thank you very much. Thank you to everybody.
Assalamu alaikum.
Wa alaikum assalam.